Welcome to the About the Face podcast, sponsored by the American Academy of Facial Plastic and Reconstructive Surgery through the Facial Plastic Surgery and Aesthetic Medicine Journal.
Welcome back to About the Face. I'm your host, Dr. Allie Burgess, and today we're digging into a small but incredibly meaningful anatomic problem that many facial paralysis patients struggle with: how to restore balance and competence to the lower lip when dynamic recovery just isn't possible. If you work in the realm of facial paralysis and reanimation, you know the conversation tends to center around restoring smile, eye closure, or brow movement. But for many patients, the everyday frustration isn't just the smile, it's their function. It's lip biting, leakage when they're drinking water and other liquids, slurred articulation, or persistent elevated lower lip that worsens their quality of life. Today's discussion focuses on a technique that addresses exactly that. We're talking about a recent article titled Lower Lip Fascia Lata Repositioning in Flaccid Facial Paralysis, published in Facial Plastic Surgery and Aesthetic Medicine in 2025. And joining us is its senior author, Dr. Sam Oyer, facial plastic and reconstructive surgeon and fellowship director at UVA. Dr. Oyer, thanks so much for being here.
Yeah, thanks so much for having me, Allie. I'm really excited to talk about this topic because I think it can actually make a huge difference in the day-to-day life for patients who have lower lip paralysis. Now, just to be clear, this wasn't a technique that we particularly developed, but we modified it from an original description that I found from Japan in 2007. So personally, I found it to be such a helpful and straightforward technique in my practice that I really wanted to highlight it in this publication so that other surgeons who face this dilemma in their patients have this tool to add to their toolbox. And I think it's really easy for most of us to incorporate this into our practice, especially if you're already doing facial reanimation surgery.
Wonderful. Well, let's set the stage for listeners. So when someone loses function of the marginal mandibular branch or the lower buccal branches, the lower lip loses its function and gets pulled upward and inward. Patients sometimes describe accidentally chewing on their lip, struggling to seal liquids, and difficulty forming certain consonants when they're speaking. And also they can have lower lip asymmetry with their smile.
Yeah, exactly. And one challenge we face is that our traditional toolbox really isn't great for this particular problem. Dynamic reanimation would obviously be ideal, but the reality is that not every patient is a candidate or, in fact, interested in a multi-staged operation that involves nerve transfer or free muscle reconstruction. Digastric muscle transfer is kind of an alluring option for this problem, but achieving consistent dynamic results with this tend to be pretty disappointing for a lot of folks overall. So that's unfortunately come up a little bit short. One option that we often use instead is either Botox or myectomy on the opposite unaffected side. And while this can certainly help with symmetry, it really doesn't fix the fact that the paralyzed side still sits too high and often interferes with function. So you can weaken the intact side enough that everything looks straighter and looks more symmetric, but patients actually lose some lower lip control with this, and it decreases their dental display overall. So in essence, you're trading one problem for another.
Definitely. So we've had this clinical dilemma for a long time, and we're wanting a reliable, reproducible, and meaningful solution without asking the patient to go through a major reconstructive effort. And that's really where this technique fits in. For listeners trying to visualize the approach, this isn't a standard sling. It's not simply lifting or suspending the tissue. It's more like redefining the baseline position of the lip, giving it structure and balance without forcing it into a rigid, unnatural posture. Can you walk us through how the procedure works?
Yeah, sure. The operation is typically done under conscious sedation, and that's intentional. This allows the patient to open and close their mouth somewhat during the surgery and really helps us fine-tune the tension in real time to avoid overcorrecting the lip position and making it too low. So we start with harvesting a strip of fascia lata from the lateral thigh, and then a mucosal incision is made along the wet, dry junction of the lower lip on the paralyzed side. 2 additional tiny incisions are made, one at the nasolabial fold near the modilus, and then one just below the mandible. And this gives us access points for the approach and the fixation. So then tunnels are made between these incisions, and you create a subcutaneous passageway to pass the fascia through. So one limb of the fascia sits horizontally across that lower lip and is secured medially near the midline, and then laterally into the modiolus. This is tension slightly to help lateralize and then stabilize the lip in that horizontal vector. The second limb travels obliquely from the lip down to the mandible, sort of replicating the direction of the paralyzed DLI muscle. We loop that oblique strip around the horizontal one and set the appropriate tension, securing this down to the mandibular periosteum. And what you get is a two-vector support system that gently brings the lower lip down and rolls it outward.
Great. And it's great to visualize that two-vector support, especially with the looped construct that is so elegant, giving the lip controlled movement instead of freezing it. And by attaching this to the periosteum, when you open your mouth, the lip can depress instead of staying fixed so the lip doesn't ride up between the teeth when eating. What's the recovery like for patients?
Recovery is pretty straightforward and usually well tolerated. Typically, I recommend a soft diet for the first few days just so none of the sutures get pulled out. Then most of the swelling resolves in a few days to a few weeks. The incisions are usually virtually invisible once they're fully healed. And because the benefit is really structural, patients don't need to, quote, learn to use it. They don't have to wait for reinnervation or anything like that. They just experience less lip biting and a little better lip seal, along with restored balance right away. One thing I always warn patients about, though, is that they'll feel a little more fullness in the lower lip from the fascia after that procedure, and that will persist.
Got it. That's great. And are there good candidates for this procedure that you identify in clinic?
Yeah, the patients that are ideal for this procedure are ones that have stable, flaccid paralysis of the lower lip, where the lower lip asymmetry is persistent and then really functionally bothersome. So to me, it's patients who are constantly biting their lower lip, saying, I can't really drink without really thinking about it, or I constantly bite my lip when I'm trying to open my mouth wide to chew on a bite of sandwich. Really, cosmetic improvement and symmetry is certainly part of it. But I think the bigger win is reducing that interference with eating and speaking and improving that lower lip excursion when they open their jaw.
Absolutely. That makes such a big difference on their quality of life, I'm sure. And the outcomes reflected that. The example photos in the article show a clear reduction in height discrepancy and a more natural, relaxed, at-rest lip position. So that was really great to see visualized in the manuscript. So before we close, when you're explaining this option to a patient, how do you frame expectations?
Yeah, I try to tell them that the goal is not really to restore motion. The goal is more about restoring balance. So their lower lip will sit in a more natural position. It'll protect itself from being bitten and participate more normally in speech and eating. Some patients physically hold their lip over when they're talking, and this will help remove the need to use their hands. While it won't suddenly animate, it does stop getting in the way of daily life, and hopefully that helps patients' quality of life so they think about it less and less. Most patients really find that meaningful, especially when they're constantly biting their lip. Imagine how much of an improvement that could be.
Definitely. That would really make a huge difference on their day-to-day quality of life. So thank you so much, Dr. Oyer. That's a perfect summary. Thanks for being here and sharing your insights about this paper.
Absolutely. Thanks so much for having me, Allie.
And that wraps up this episode of About the Face. The article is linked in the show notes for anyone who wants the technique images or the operative video. See you next time.